Okay friends, welcome to the last part of your atypical uterine bleeding. Now, last video I think we have studied about the investigations and treatment and surgical options which we have for AUB. Now we will understand how it differs for a specific case. Okay, so coming to AUB, we have studied everything. The important thing which you should know is classification, that is palm coin, structural, non-structural, and structural. You have palm. What is palm? Yes, say along with me: polyp, adenomyosis, leiomyoma, malignancy. Good. In non-structural, what do you have? Coein. COIN. What is C? Coagulatory defects. O. S. What is O? Ovulatory dysfunction. What is I? Iatrogenic. What is N? Not otherwise classified. So what I thought was, in this video, how an AUB patient comes to you in this case is what I will discuss, so that you will have a general approach based on our second video. So first, starting with polyp. Correct. Now, history, examination, investigation. What history do you think should come with? Obviously, what is the topic? AUB, right? Should come with AUB. Then, if it's a cervical polyp or a lower uterine polyp, one of the differential is the polyp, so she can come with mass protruding. Very rare, but coming. She might come. That's the one thing. Examination, obviously you might feel everything is normal. Based on this, depends on where the polyp is, right? Then again, in the first video we have explained why polyp causes AUB. That I am not discussing now. Okay. And then investigation, same. What is the first? UPT. Never forget. Okay, never. You should never do this mistake. Otherwise, you will be screwed. I mean, you will be under bus. If you want, you can do it. Okay. Then you do a TVS or TIS based on the specificity and sensitivity which you desire and patient wants. Okay. Then you will find out a cause. She has a polyp. Then what you can do? Treatment. Either hysteroscopically. I mean, if she is asymptomatic and if she can manage on medication, start her on trans or tranexamic acid. I'm sorry. Then progesterone. Then later, if she wants to get it removed, if it is see, when is the problem? When any disease, when it interferes with the normal day-to-day activities of a person's life, you consider it as abnormal. Then you start her on management, either medical or surgical. Best is hysteroscopically remove the polyp, that is hysteroscopic polypectomy. If she is post-menopausal woman, if she is having multiple polyp, remove the uterus. Okay, this is one case of polyp. So now you understand how does the case of polyp presents and how do you go about it. Then you have a case of adenomyosis. This is polyp. Okay. See, adenomyosis patients are very classical. Okay, once you see them, you never forget. So they come. Usually the age will be more than 40 years. They will complain of AUB and they will have what? Pain. Why do you think there is pain? I have explained in first video. Recall. Because here endometrium is invading to the myometrium. There it is causing chronic inflammation. So what is being released? Prostaglandins are released. So this causes what? Pain. Okay. So this is so classical. If a patient comes to you with AUB and if she is more than 40 and if she has a dysmenorrhea and there is one more triad, okay, which you will comment down in the comment section. Okay. If these three are there, then you can almost clinically clinch a diagnosis of adenomyosis. Okay. So again, investigation gold standard is, yes, I taught in last video, MRI. Okay. Then treatment, specific thing. If it's a same post-menopausal, do hysterectomy, or you can remove the endometrium layer which is invading the myometrium. That is one thing. This is of adenomyosis. Okay. Next, leiomyoma. The most common cause, guys. Come on, say me. What is it also called as? Fibroids. So based on where it is there in the uterus, you can classify fibroid into different stages. Either it can be uterine or extrauterine. I think we can have a separate class on that. I'm not discussing as such. Okay. So when do you think is a problem in fibroids? If it's intervening in her day-to-day activities. She has complaints of infertility in case of bilateral corneal block. Okay. So what you can do? Postmenopausal. Yes. Yes. Hysterectomy. Y plus BSO. Or if she wants it is a reproductive age female, remove the fibroid which is present. Okay. Then coming to malignancy. What do you think you can do in malignancy? What malignancy will bleed? Whether C endometrium will bleed? Yes. C ovary? Yes. C cervix? Yes. All will bleed. So based on other symptoms, concomitant symptoms which are present and specific investigations which you order, for C endometrium you should do an MRI to know till where it is involved, and also in CS cervix also you should do MRI because to know the parametrial involvement. What is parametrium? The ligaments which are attached. So this will almost change your treatment action and treatment plan. No? So this is something which you should know. Then C ovary also you should do. Then based on this, you can either have stage 1, stage 2, stage 3, stage 4. If it's a local disease, surgery. If it's regional disease, surgery plus chemotherapy. If it's if this is the first stage, then you have to follow something called as palliative care, where you can start here also an NACT plus RT, that is radiotherapy and neoadjuvant chemotherapy. That is before surgery you give the chemotherapy. This is palliative. Mostly you don't do surgery here because there is no point. It's a systemic disease here. If it is causing some other problems related to other structures, yes, you remove that. Otherwise, funda is do palliative care, give chemo, radio, and see how many days they survive. Okay, this is about malignancy. So structural causes, you got an idea. That is all this. Can we create a specific, pattern? Yes, usually more than 30 to 40. Okay. Any structural abnormalities, you say they will have AUB with all these things. Almost the investigations is also something same. Radiological, then suspect. If it's more than 4 or if it's more than 12, suspect. Pathology, endometrial biopsy. Almost it's same, investigation part. So you need to see at the end you can't remember everything. It's almost 12 subject for us, right? So you should form a particular approach for a particular thing. So this is for structural. Now coming to non-structural part. Okay. Non-structural. What do you add? Coagulatory defects, ovulatory dysfunction, iatrogenic, then not otherwise specified. So coagulatory defects. See, this is a classical patient who comes to you with 12 to 14 years, who has attained menarche very recently. There is no pelvic pathology, there is no pathology anywhere. You do a blood test, you find there is a low platelet count. There is any other features of bleeding or coagulating defects. You do a VBD testing, that turns out to be positive. So management is according to the patient. You can give a VWD or you can give a platelets or something which is desired. Okay, this is something to do with coagulation. This is more of functional. That means this is not something to do with OBGYN, so I'm not touching that part. Okay. Then ovulatory dysfunction. So in ovulatory dysfunction, you can either have, I think I've already taught you this, estrogen, progesterone concept. Why in progesterone there is release of PGE2 when there is a fall, so this causes pain, and here it doesn't cause pain because it is just a friable mass of endometrium. So again here what do? Here the best thing is what? Hormone. No, so hormone is something which is affecting. So than starting around tranexamic acid, start around progesterone, try to stabilize the endometrium and the uterus. Then later, related management you can do. Then iatrogenic. What do you think is the most common cause? Yes, IUCD insertion or prescribing or other contraceptives, or which has more of other problems. Iatrogenic is something which you induce as a AUB. Okay, that is something which you should know. How does it causes? Something which you would read up. If it's a IUCD problem, then you remove the IUCD. If there is an infection, start her on antibiotics if required. Okay, not otherwise specified is if you are unable to classify this patient into any of the categories which you have mentioned, then it comes under not otherwise specified. So now see, every approach you got. Okay, I know this was a huge session. See, but at the end, you know what you are supposed to know. If a patient comes to you with AUB, okay, now you know the workup of each specific disease of each specific person, which is a tailor made, which I told in the first video of AUB. I hope it's clear. Correct, no? So now, excuse me. Now a specific thing, okay? Specific questions and specific things which you need to ask to a patient. For example, what history you would like to ask if a patient comes to you with AUB? Last menstrual period, okay, then duration, frequency, then what was the whether she is passing clots, which indicates that maybe menstrual bleeding, and features of anemia like fatigue, on examination to find pallor or something. Then you can also say it's kind of AUB. Then you start do the biochemical test, which is the CBC and related stuff. Even the endocrine, if you are suspecting any hyper or any prolactinomas, then starter on check hemoglobin levels. If it's a case of HMB, that is heavy menstrual bleeding, you know the protocol, how to go about it. If it's not HMB, then starter on medical management. You can either starter on tranexamic acid or progesterone based on the cause. Okay, ovulatory is you can start on hormones, progesterone. Why tranexamic acid? You know that's not local. Okay. Then in postmenopausal women, one more thing which I would like to mention is, if it's a postmenopausal woman coming with bleeding, it's always pathological. Please mark it somewhere, okay? A postmenopausal woman coming to you with bleeding is always pathological. She need to be evaluated. Postmenopausal women with bleeding is always pathological. They say almost 50 to 60% cases is because of SME, atrophic vaginitis. Okay, so it becomes lax. Here you can start her on some estrogen creams, local creams you can start. But what is the major part? CA cervix, CA endometrial. These are the things which causes problem. So it's always pathological, and you should always do a proper investigations and workup in case of a postmenopausal woman. Okay, in reproductive age or in adolescence, it's usually annual cycle, something related to hormone imbalance, HPO axis immaturation, all those things. Started on the protocol which is present. Started on hormones or tranexamic acid. Better start on tranexamic acid. You should not expose people to hormones, which you should know. Progesterone is quite safe, but based on the indication, again, it's all about classification. So if you know the classification well, and if you know how to approach a patient, I think this is sort. I hope you will never have a problem in AUB. See, again, polyp is a specific disease. A separate video has to be done based on that. Adenomyosis is separate thing. Leiomyoma is separate thing. Again, there is other, there's a specific FIGO classification of CA cervix, CA ovary. Again, it's something which is very different, which I cannot cover in one video. So what I think my approach is complaints and how do you go about it. More of clinical. If you know clinical part, then obviously reading textbook should be easier. Okay. I think for this, for now, I think this should be enough. And also one more thing, if it's a heavy menstrual bleeding, than starting on progesterone as such, it's always good to give endometrium. See, this endometrium is the one which is required. Estrogen. I'm sorry. Estrogen is the one which is required to express the. See, if estrogen is present, then progesterone can act. Okay, so you started on estrogen, then you started on progesterone. Okay, now you know the cutoff. I think it should be good for you to approach a case of AUB. I think you should not have a problem. even as a primary healthcare physician. And if you can't, obviously at the end, refer to a gynecologist. Okay. You know the approach. I think you know the workup now. I think this is enough for the class of AUB. I think you are well equipped to manage, at least in a primary healthcare center. That is what is the most important thing. Okay. Fine. Thank you. Have a good day.